Hi, I'm Curtis Lachowiez at University of Texas MD Anderson Cancer Center, and I'm going to talk briefly about our trial, phase 1b/2 trial of the combination of Ivosidenib, the IDH1 inhibitor, in combination with Venetoclax, with the addition of Azacitidine in IDH1-mutated myeloid malignancies that we'll be presenting at EHA this year. So this was a phase 1b/2 trial. It has enrolled 3 cohorts that will be presented at the meeting, and we actually just completed enrollment in the 4th cohort. The main trial objectives were to determine the safety and efficacy of the combination of Ivosidenib with Venetoclax. This combination was a rational therapeutic combination based on preclinical data that demonstrated IDH1-mutated malignancies have an increased dependency on the anti-apoptotic protein BCL2, for which Venetoclax is an antagonist of. And so there was synergy seen in preclinical models, and whether or not this translated into increased clinical efficacy and was safe had yet to be determined. The trial, the first 2 dose levels, so dose level 1 enrolled 6 patients treated with Ivosidenib plus Venetoclax at 400 milligrams. Dose level 2 enrolled 6 patients treated with the same dose of Ivo, 500 milligrams oral daily, in combination with Venetoclax at 800 milligrams daily. The reason for this increase in Venetoclax dose is some of the preclinical work has demonstrated that Ivosidenib increases Venetoclax metabolism. And so in order to achieve a therapeutic concentration of Venetoclax, we tested a higher dose level of 800 milligrams of Venetoclax in combination with Ivo. And then dose levels 3 and 4 have enrolled patients. So dose level 3 that will be presented at the meeting enrolled 13 patients treated with Ivo plus Ven 400 milligrams, but with the addition of either intravenous or subcutaneous Azacitidine. And dose level 4, which just completed an enrollment, and we do not have the data for at this time, treated patients with the same schema with the incorporation of Azacitidine, but with an increased dose of Venetoclax at 800 milligrams, similar to dose level 2. The early safety signals from the trial show that both doublet and triplet combinations are safe. The most common adverse events that we observed were fever and infectious complications that we commonly see in myeloid malignancies, febrile neutropenia and pneumonia being the most prevalent, seen in approximately 1/3 of patients. We didn't observe any 30 or 60-day mortality on study, which of course is reassuring. When you're using Ivosidenib and Venetoclax, there's 2 adverse events of special interest that need to be kept in mind, and this includes the IDH differentiation syndrome that can occur with IDH inhibitors, so Ivosidenib, and tumor lysis syndrome, which has been observed with Venetoclax. We did observe these events in this study, though we were fortunate that they occurred in the minority of patients. So 4 patients developed the IDH differentiation syndrome. All of these resolved with medical management alone. And 2 patients developed tumor lysis syndrome, which was considered a dose-limiting toxicity in 1 patient, though again, reassuringly, all of these adverse events of special interest resolved with medical therapy alone, and where patients were able to continue on study. As far as the efficacy of the combination, the doublet combination as well as the triplet combination were effective, and there were some nice, exciting signals from both the doublet and the triplets. So at the increased dose of Venetoclax, 800 milligrams daily, we saw increased composite complete response rates. So all 6 patients enrolled at dose level 2 achieved a composite CR. At dose level 3, with the addition of Azacitidine, we also saw high composite CR rates, with 85% of patients achieving a composite CR. The 2 patients that didn't achieve composite CRs, one had a partial response and the other one was in a morphologic leukemia-free state when they proceeded to allogeneic bone marrow transplantation. So overall, all patients in dose level 3 also responded. So the overall response rate was 100%, similar to dose level 2. At dose level 1, we did have 2 patients that were non-responders. These were both relapsed refractory AML patients. The survival also was incrementally increased across the dose levels. So we saw a 1-year overall survival of 50% at dose level 1, 67% at dose level 2, and 83% at dose level 3. It should be noted, though, that the balance of this was a heterogeneous patient population. So it was a mix of patients with MDS or MPN or newly diagnosed AML or relapse refractory AML. And so there were more relapse refractory patients in dose levels 1 and 2. And so these results have to be interpreted within that context. I think also, fortunately, in AML, one of the things that we're always thinking about is how we can deepen the response up front in the terms of measurable residual disease. And we did see that we saw incremental increases in MRD negative composite CRs in AML patients, both newly diagnosed and relapsed refractory, at the dose level 2, within the dose level 2 cohort and the dose level 3 cohort. Future directions for this study are, right now, like I said, we just completed enrollment in dose level number 4. And so after that, we'll move forward with the phase 2 portion of the study. And within this, I think one of the key points that everyone is always striving to do is to figure out what patient population the treatment works best in. And so with this comes a lot of rich correlative analyses that are ongoing and planned. We still see the signal in the cohort as a whole that signaling mutations appear to portend an inferior prognosis with at least the doublet therapy of Ivo plus Venetoclax. We had a very small number of patients with signaling mutations at diagnosis. Within the triplet cohort, there's only 3 patients with signaling mutations. However, when we looked at survival in these patients, it was equivalent, if not slightly better. No, it was not statistically different between patients with or without signaling mutations. So it's thought-provoking and hypothesis-generating at best. But the question lingers whether or not the triplet combination with the early incorporation of azacitidine may overcome some of the primary resistance seen with signaling mutations, which has been well described in several elegant papers for both IDH1 and IDH2 inhibitor monotherapy.